Welcome to our National Conversation, a podcast in which we discuss politics from all angles. We are completely nonpartisan, and all views, respectfully stated, are welcome here. Our podcast is unique in that it is hosted and run by students who are focused on finding solutions to the biggest problems facing America. Welcome to this edition of Allow Us to Explain. My name is Jordan Broking, and I serve as the Director of Media here at ONC. Earlier in this series, we spoke about the cannabis legalization across the U.S. and the different pros and cons regarding that. Now we are focusing our attention on another hot-button drug issue in the country, this time surrounding opioids in the country and fentanyl. So, the questions regarding this: how do we get here? What are opiates? And how can we move forward with treatments and moving this issue to a more rebound solution? So, in today's episode, we are joined by social issues intern Ronan C. And as our nice little special guest, we are also joined by Dr. Helena Hansen. So, Dr. Hansen, since you are a special guest here, would you mind introducing yourself first?
Not at all. So I am an anthropologist and an addiction psychiatrist. I specifically got joint training, MD, PhD training in social science and medicine because I'm really interested in how the social environment and social influences drive health outcomes. And I'm increasingly, I think all along I've been interested in inequalities in health. And I'm increasingly working on how our economic system in the United States and the way that we think about and organize people by race is directly responsible for the kinds of health outcomes that we're seeing now, not only among non-white people, but actually also among white people. And I can elaborate on that in a bit, but I did a very long study culminating in a book called Whiteout, How Racial Capitalism Changed the Color of Opioids in America, about how structural racism in our pharmaceutical industries and healthcare industries actually ended up harming white people as well as non-white people through inbuilt stereotypes about white people being less vulnerable somehow to addiction, less subject to some of the risks of opioids. So with that, I'll turn back to the questions that you have.
Well, great. Thank you so much. I'm looking forward to actually diving deeper into that. I think that's another important topic that I think is kind of overlooked sometimes when we're talking about this topic. So looking forward to hearing your input on that. And Ronan, would you mind introducing yourself?
My name is Ronan C. I'm a social issues intern, and I've been on the podcast before, sometimes a bit more vocal, sometimes not. I'm just really kind of looking forward to having a really good discussion and learning some new information on a topic I feel pretty passionate about, because as someone who is in college and as someone who is an avid festival goer in his free time, you kind of have to learn a lot about opiates and a lot of this kind of stuff with anecdotal evidence, and more so sources like Reddit and 4chan that could be arguably dodgy. And I'm just really looking forward to learn, share my opinion, and be proven wrong, and kind of get a new perception with this discussion.
Perfect. Well, then let's get this conversation started. So just kind of break it down just to the very basics of what we're talking about here first. Obviously, I think everyone has heard about the opioid epidemic at one point in their life, given how much of a rising problem it's becoming in the country. So, Dr. Hansen, I'll let you start first with this first question I'll ask. What are opiates exactly, and why is it in particular so dangerous, especially regarding both medical and non-medical use?
Great question. So opioids, maybe I'll start with the difference between opiates and opioids, because as someone who trained in addiction psychiatry, I had to spend a little bit of time on that and understand why that's important. Opiates are naturally occurring, and they, for the most part, come primarily from opium poppies that are found in the naturally growing in the Middle East and in many parts of Asia. And they have been for many thousands of years been used medicinally by humans, usually for pain, Sometimes for other things like for cough, they actually are great for cough suppressants. And for sleep, they definitely make people sleepy, which is why they're called narcotics. So the root of the word narcotics, narc, really refers to sleep. And so opium poppies have been with us for thousands of years. Opium tinctures and derivatives of opium poppies that have opium in them have been with us for thousands of years and used in a lot of different ways by human beings. And more recently, in the late 1900s, another form, so in the 1900s, morphine was a very widely used concentrated form of opium derivative, and it was injectable. It was used for pain among Civil War veterans and soldiers. There was in the 1800s, following the Civil War in the US, a lot of discussion of the veterans' disease, which was dependence on morphine because they'd gotten addicted to it, in the battlefield. And then there were housewives who had been given injections of morphine as kind of this miracle pain cure for everything from lower back pain to menstrual pain. So Victorian era housewives that had the money for private doctors would have doctors come by and give morphine injections. So morphine was kind of the next step up from these opium tinctures and opium derivatives. It was very concentrated. And then as the problem of addiction became very evident, a new form called heroin was developed in a lab, derivative of opium poppies. In 1898, Bayer Pharmaceuticals, the ones that make our buffered aspirin to this date, they marketed heroin as a non-addictive alternative to morphine, if you can believe it or not, and set off in a couple of decades yet another wave of addiction as heroin was added to all kinds of household over-the-counter products, in the corner drugstore. So, these products have had a very long history with us. We know through the 20th century what kinds of problems heroin had led to, and I can get back to that in more detail. But what we are confronting now in 2023 is a set of synthetic opioids. So they are not derived from opium poppies. They're developed in laboratories. Fentanyl, which some of you may have heard of because it's caused a lot of overdose deaths in the last few years. Fentanyl is a synthetic opioid. And the term opioid, as opposed to opiate, refers to the fact that it's synthetic. And it has the same kind of action as opiates, naturally occurring opiates. It is active at opiate receptors in the brain. So our brain cells have receptors that are for this type of molecule that cause all of the effects that go along with it: sleep, pleasure, pain relief. But the synthetic opioids that are made in labs, many of them are way more potent than the naturally occurring derivatives. So for example, fentanyl is about 100 times as potent as heroin, meaning you only need 1/100th the amount of fentanyl to have the same effect as that amount of heroin. So because too much stimulation of this opiate receptor in the brain causes people to stop breathing and then therefore causes overdose deaths, these very, very potent synthetic opioids are much more likely to kill people because people do not know how strong it is, and they will inadvertently take way too much to the point where there's so much of that synthetic opioid stimulating the opiate receptor in the brain that they stop breathing entirely. We have these very dangerous street markets now with fentanyl often being sold as heroin. People do not know what they're getting. And as you can imagine, it's much easier to smuggle these synthetic opioids like fentanyl. If you only need 1/100th the weight as you need of heroin to get the same effect, that means if you're smuggling drugs across the border or on an airplane or whatever, you have a much smaller volume of product to get across. And so it has become wildly popular with cartels and street marketers. And so that is one thing that's leading to an incredible uptick in the number of deaths from opioid overdose.
Ronan, do you have anything else to add? They think it's also important to include.
I hate to sound like a fool, but I honestly just learned something. I did not know there was a difference between the two with the synthetic part, so I really actually have nothing to add if we're going to talk the more scientific terms. So I apologize. I have nothing to add, but I'm not going to overstep what I don't know. And I learned something new, and it was all honestly really fascinating to learn.
Sweet. Well, then we'll move along with this conversation then. So, when we are looking at the issue here, how do we get here when it comes to this rise in opioid addiction, fentanyl addiction? I think we've all heard different roles or different parties being involved with this, where this is the medical industry itself, the role of pharmaceutical companies. I think, especially here in New York, a number of pharmaceutical companies sued because of their role in it. So how do we exactly get here? And I think this is actually the perfect segue for you, Dr. Hansen, kind of talk about the prominence of fentanyl kind of rising and why it's becoming such a prominent drug on street markets as well.
It's a fascinating and complex story, and one that I and my co-authors trace out in the book that I just mentioned, Whiteout. So epidemiologists of overdose and opiates versus opioids have come to talking in terms of four waves since the 1990s of opioids and opiates that have caused overdose and addiction. The first wave started in the late 1990s with the marketing of OxyContin and a number of other products that are similar to OxyContin that other companies brought to market right after OxyContin was approved. So OxyContin, the innovation there, Purdue Pharmaceuticals, and many listeners may have heard this story. The owners of Purdue have been subject to a lot of lawsuits. And they've had their names removed from a lot of, universities and buildings that they had contributed to. So they're kind of infamous now. The Sackler family that owned Purdue Pharmaceuticals, they had a breakthrough with OxyContin by selling it to our federal regulators, the FDA, as well as the DEA, as an almost non-addictive opioid pain reliever, because it took oxycodone, which is an old opiate, really, took oxycodone and embedded it in a sustained release capsule. So whenever a person takes an opiate or an opioid, if you take a large amount of it all at once, you get kind of a rush to the brain and a pleasurable high from it. And by putting the oxycodone in the sustained release capsule, it only released a little bit of the opiate at a time. So it effectively controlled pain, but it didn't give this rush to the brain that causes a lot of pleasure and causes addiction, in essence. So they were able to sell this as this miracle technological fix to the problem of the addictiveness of opiate pain relievers. And the FDA actually bought this story and approved it for widespread use. And that enabled the company to go around and market it very aggressively to primary care doctors and to people who weren't used to managing very potent opiates in their daily practice. Up until the mid-90s, really opiates like oxycodone had been restricted to surgeons, people treating cancer pain, very, very severe acute pain. But with this FDA approval of OxyContin as a minimally addictive, quote unquote, opioid pain reliever, the manufacturer was able to very aggressively market it, going around, sending drug representatives around to primary care doctors. They focused on suburban areas and often rural areas. They focused on white populations because those populations weren't suspected to be as prone to addiction. That had been a very well-established pattern in all studies of physicians and who they were willing to prescribe opiates to. So they were very kind of savvy about how they approached this because they got it designated as minimally addictive. And then they also marketed in a way that didn't raise a lot of flags, often based on racial stereotypes. But they were wildly successful. In many states, it led to a 10 times increase in the number of opiate prescriptions. And they were only one of many companies that took advantage of this window of opportunity. So by the late 90s, it was very clear that overdose was an enormous problem. And it was concentrated in suburban areas and rural areas, places that, hadn't been used to seeing a lot of opiate overdose. And because it was specifically marketed there. And so by the early 2000s, there were a lot of calls for prescription drug monitoring programs to be put in place. There were a lot of statewide controls on opiate prescribing. And so it became much harder for people who are looking for opiates to get them. And in addition, the manufacturers of these sustained release capsule formulations, what they did was they began making tamper-resistant formulations. So, for example, formulations of the opiates that would turn into gummies if you tried to crack open the capsule. That's a detail I left out. The way that people wanted a rush from OxyContin, the way they got it, was they just simply cracked open the sustained release capsule. No one had thought about that. No one at the FDA stopped to think, oh, couldn't people just crack open this capsule? Because it was sold as this magic bullet. People forgot, that they forgot about the context in which people use these things. So the OxyContin's manufacturer and the companies manufacturing similar products, they started making tamper-resistant formulations. So if you cracked open the capsule and tried to, say, dissolve the contents in order to inject them, they'd turn into gummies. They were very difficult to snort. So they did a lot of things to prevent the non-medical use of these products. So the combination of prescription drug monitoring programs that tracked prescriptions very closely and subjected doctors and other prescribers to actually criminal charges if they didn't check a statewide database to see if a patient was doctor shopping and getting narcotic prescriptions elsewhere. The combination of those laws plus the tamper-resistant formulations meant that people who had already been addicted to the opiates went to street markets. They had to go for heroin being sold on the street, because it's a similar compound. Heroin has the same effects on the opiate receptor in the brain. And so they would be going into withdrawal, really literally having withdrawal, very serious withdrawal symptoms from not having access to opiates. And the easiest way to get opiates at that point in time, because the prescription opioid supply was drying up, was to buy heroin on the streets. That gave a big boon. So this is wave 2. I think this gave a big boost to the heroin markets. Cartels were going crazy. They were getting a good foothold in rural America, small town America, places where heroin hadn't traditionally been so easy to get. Because prior to that, heroin was much easier to smuggle into big port cities. So, New York City, San Francisco, Los Angeles, big ports where ships could come in and undetected with heroin. So up until then, these other areas, small town America, rural America, they hadn't really had the heroin supplies that all of a sudden they were getting. So then we have wave 2 of heroin overdose, right? And that got a lot of national notice. So because there was so much crackdown on heroin trade and it was so much easier to smuggle in fentanyl, these synthetic opioids that I just described, that only, like in the case of fentanyl, only require 1/100th the amount of the opioid. The heroin markets that had cropped up in all these places turned into fentanyl markets. We're seeing, on top of this huge uptick of overdoses, first from prescription opioids and then heroin, now we're seeing an even bigger uptick in overdose deaths because of fentanyl. It's so much easier to overdose on fentanyl being so potent. And what we're also seeing, that was the third wave. So fentanyl and synthetic opioids is the third wave of overdose in the country. Now we're going into the fourth wave, where we're seeing polysubstance use and polysubstance overdose deaths. Part of this could actually be people who are addicted, dependent on opiates, trying to transfer that to other types of substances to avoid the risk of overdose. But what's happening is that people are using opiates in addition to stimulants and other classes of drugs. When they die of overdose, they're found to have high doses of all these things together, and they may actually be compounding the effects and leading to an even higher risk of overdose. Another thing that's happening is that fentanyl, because it's so potent, if there's any contamination of, say, a stimulant supply with fentanyl, that's easy enough for that to happen, people will die of overdose from the fentanyl that's in their stimulant supply. So people actually don't know what they're getting on the open market these days. And so that's the fourth wave. The fourth wave of overdose is polysubstance use and overdose from multiple substances in the street supply.
No, I think that's very interesting. I think a lot of people, they may think about heroin here and there. They might think about fentanyl, but I don't think they've really kind of considered like the actual first wave before heroin, and also now, these other methods that people are now using, as you just mentioned, to actually try to avoid overdosing. But unfortunately, addiction is a big wide issue, still affecting many people to this day regarding fentanyl nowadays, opioids, opiates. So this question is to both of you. What or how has addiction specifically, when it comes to opioids and some narcotics like fentanyl, how has that impacted, American society, throughout history, really, since it's, first came to the market, and nowadays with what we're seeing regarding different stories about people either being, hospitalized or dying because of it. How has addiction really affected the American society?
Sure, I'd like to start. I know I'm probably not going to have as much scientific facts as you, which I kind of wish, but I would say my anecdotal evidence could be relatable. So basically what I was thinking is opioids just kind of well, kind of as you stated, just makes it so easy for people's lives to be ruined because the high is so prevalent. And I think something that really kind of resonates from what you were saying was the fourth wave addiction with especially with fentanyl. With as someone who was in college, and there's a lot of different kind of substances that are being passed around said colleges that are laced with fentanyl or different kinds of very prominent opiates. It makes people either extremely addicted to them, and it's not even a legitimate substance, or people overdose and die. Just simple as that. And it could be even people that I've known people that have overdosed because, oh, they took fentanyl. And it's kind of like, even when people think it seems growing up like, oh, we knew about opioids, but there was always a way for them to be brought back in, even when we knew to stay away from them, especially with fentanyl. Oh yeah, don't do heroin. We kind of knew, oh, don't shoot up needles. And then, people go to concerts or they go out downtown, and there's substances like cocaine, MDMA, Adderall, which are, I'd say, kind of party drugs, and they take something, they don't know what's going on. And I think when I mean anecdotal, this is more kind of like the social kind of just analyzation, and they get hurt or they die because they don't know what they're doing. They make a reckless decision, and it leads to a very unfortunate consequence. And I know that's kind of a simple phrasing, and I bet a lot of people might actually kind of relate to that, and you could definitely add on that. But that's kind of when I think of opiates in the social scenario now. It's like everyone, my mindset is, if I go out, I want Narcan or a drug testing kit on me, because I don't want to risk my life if something is going to happen. And it's I always have to be reminded of that. And it's a little bit of a fear, because I care about my well-being. It's oh, I don't know what's going to happen if I don't come prepared safely.
That's so well said. So one of my graduate students published on this, and I was a co-author, that according to our national databases, between 2019 and 2020, there was an almost 100% increase in overdose deaths among adolescents, teenagers. 100%. And then the following year after that, an additional 20% increase. So what we're seeing is an all-time record high number of overdoses among people in adolescence, teenagers. That's really, really concerning. And it reflects exactly what Ronan was describing, that people who are not necessarily longtime substance users that are, just experimenting, just trying something new, may end up dead as a result of that initial experimentation because of the toxicity of the drug supply that we're seeing right now. And I think it's very important to understand how the drug supply got to be so toxic. And the reason is the Gen Z generation is going to have to confront drug policies, is going to have to think about how do we operate as a society to avoid the very dilemma that we're in now moving into the future. There's something called the iron law of prohibition. So to put a little historical context, most people have learned, I think, somewhere along the line that we had an era of, it was only 12 years. It was in the 1920s up to the early 1930s. We had an era in which alcohol was prohibited, just like heroin is to this day, right? And so what happened right after alcohol was prohibited, and it was for very well-intentioned reasons. Alcohol was connected to a lot of domestic violence, a lot of car accidents. There's so many, a lot of deaths. So, alcohol is not a benign drug. It causes a lot of deaths. And there are very well-meaning reasons why they prohibited alcohol in the 1920s. However, what they discovered after prohibition is that the number of alcohol-related deaths went dramatically up, because the alcohol wasn't being regulated. There were no government agencies checking on the contents of what was being sold as alcohol. People were making alcohol in their bathtubs, and often they would accidentally make methanol instead of ethanol, which is a very lethal type of alcohol. And so there were just so many negative health effects from prohibiting alcohol that eventually, and not only that, but societal effects. The prohibition of alcohol led to a dramatic expansion of the mafia in this country. And so, a lot of killings related to mafia organizations around control of illegal alcohol markets. This, to make a long story short, we're seeing the equivalent of that right now. What we're seeing is that with increased law enforcement, we as a society are very prohibitionist. When we see a dangerous drug, what we do is we try to crack down on the sellers and the cartels. What that has done, and it sounds good, like if something's killing people, let's get it out of the way, let's get it out of the market. But practically speaking, what happens is that then creates a very, very lucrative, very good money-making market for illegal sales that are going to be irresistible to the illegal cartels. And that's what we've done with the opioids, is we've created a massive, really incredibly profitable opioid and other illicit drug market where nothing is regulated. There's nothing that's under government control. People who want to use those drugs are forced to buy completely unpredictable supplies. And so this is what we call the iron law of prohibition. The iron law of prohibition is that the more you crack down with prohibitionist policies on a substance, the more dangerous that substance will become. It happened with alcohol in the 1920s, and it's happening now with opioids and opiates. So what many people are calling for now is for us to have regulation of these drugs. They're also calling for us, and this is already happening in the marijuana space. We've seen a lot of, an increase in cannabis industries, and for better or worse. I'm not going to say it's terrific for everything and everybody, but a similar kind of debate has happened around cannabis. How can we do more regulation and less prohibition and harm reduction? Harm reduction is a really key concept here. The idea is that we cannot eliminate addiction. It's kind of inherent in human society. There have been forms of addiction all the way along. And with contemporary urban life, addiction is going to be a problem that we just can't get rid of. It's tied in with the kind of consumerist lifestyles that we have. But what we can do is we can limit the harms of addiction and focus on public health-oriented public policies. And so I and many of my colleagues are involved in trying to help educate the public about an approach called harm reduction, where we accept that there are going to be we want to offer treatment and support for recovery of as many people as humanly possible, so that if they have problems with substance use, they can get off of those substances, but there will always be a small percentage who can't do it. And we can't do it in this period of time, may never be able to do it. And we want to keep them alive. And so that's where harm reduction comes in. It involves public health oriented interventions. And Ronan mentioned a couple of things. He mentioned drug testing. He mentioned Narcan, these overdose reversal kits. So those are examples of harm reduction. There are many other examples. For those who inject drugs, syringe exchange, getting access to clean syringes and needles is really important for preventing HIV. And a few decades ago, when I was, an adolescent, and AIDS was really, that was when AIDS was peaking. It was a national emergency. It was things like syringe and needle exchange so that people could have clean equipment that really stopped the transmission of HIV, as well as, safer sex like condoms, availability of those things. And so what we need to do is think about the equivalent for our era of overdose. And the equivalent for our era of overdose, it includes syringe exchange because people are still getting HIV, and that's a really important risk. But we also want to have, for example, what are called medically supervised overdose prevention facilities, where people who are really embedded in substance use and daily putting themselves at overdose risk can actually get immediate medical attention. And they can even use drugs in proximity to people who can give them medical attention without risking being arrested. Because one of the things that really puts people's lives at risk is to drive their use underground because they're so afraid of the police that they can't get assistance if they run into overdose or any other kind of problem. So there are a whole range of approaches called harm reduction. And I think a piece of it too is peer support and peer education. The way that Ronan was speaking, I wouldn't be surprised if he isn't already involved in peer support and peer education about how to prevent overdose and many of the problems that go along with substance use, using substances. These are all harm reduction approaches. And that's where I think we really need to be focusing now. One thing that many of my colleagues in addiction psychiatry are focused on is medical treatment for opioid addiction. We call it opioid use disorder in psychiatry. There are medications like buprenorphine, otherwise known as Suboxone, that actually are opioids, but much lower risk of overdose, that for people who cannot stop using opioids, those people can use those as maintenance medications to prevent withdrawal symptoms and prevent the need to have to go to these very toxic, illegal markets for opiates. So these are the range of options that those of us who are in the field trying to prevent overdoses are really promoting right now. We need to have many more medical treatments. We need to have harm reduction and prohibition. It sounds good. If there's a problem with a drug, let's crack down, let's get more police, let's get more law enforcement. But it actually has been causing more deaths rather than reducing the deaths. So we need a lot more focus on the public health measures that I was just describing.
Actually, I think this is kind of where maybe a discussion could start. I have a question on one of them. I actually agree with 95% of what you're saying. But when you spoke about the medical induced centers where people could take drugs, I kind of wonder, I have to push back on that a little because I'm wondering if this is going to happen, who is going to fund it? Is it going to be we, the taxpayers? And at the same time, I think there are a lot of better alternatives to do than allow people who are voluntarily doing horrible things to themselves. I'm not saying stuff doesn't happen, but it just seems like this, I say this gently, if people are going to, we have these centers where people can take drugs and it seems like we, the taxpayers, may have to pay for that. I just don't think that'd be a good alternative when I think education is a more powerful tool, or even maybe trying to get individuals into something like exercise. I believed exercise and just kind of fixing my well-being, and a lot of other people I've spoken to too, really kind of helped beat people's addiction. I've known some people who are opioid addicts that really got into fitness and were able to really change their lives. And I'm not against the centers entirely. I just think maybe instead of resorting to that, we could try to give people better alternatives to use this quote unquote negative energy or negative, like this craving of substance to something better that can help better themselves and better their mind and the body and soul, and most importantly, their health, like truly, and they won't have to pay loads of money for these horrible substances. And keep in mind that could be I could be completely wrong, but I just, as someone, I hear something like that, I'm like, and it just kind of makes me question a little bit, like the overall like legitimacy of it. But I'm willing to be wrong. But that's still the one thing that kind of just made me turn my head a little bit.
That is such a great point. And, I admit when I first heard about it, I had similar questions and it seems counterintuitive. So one thing I want to do is frame this as everything you just said is correct. as in every single intervention that you just mentioned is needed.
Okay.
So lifestyle, so we're in a society that doesn't make it easy to be healthy. There are many places in the country where you cannot find fresh produce. There are fast food restaurants everywhere, but there's not a market with fresh fruits and vegetables to be found. There are many places in this country that don't have sidewalks, don't have parks, don't have any outlets for physical exercise. There are just so many things that we need to address on a broader scale to promote health. And I have no doubt that substance use plays into that, because if people are growing up without any way of feeling good, they don't know how to eat well, exercise, take care of themselves. Drugs are a way to feel good, and drugs are being made much more available. It's much easier to buy drugs than fresh produce in a lot of neighborhoods. So we definitely need that. And even for people who have very serious problems with addiction, I've seen this myself as someone who's treated patients for addiction. We don't in medicine, in medical care, we don't pay enough attention to those kinds of lifestyle things, because we're often fixated on prescription pharmaceuticals and medical treatments, and we forget to ask patients, what are you eating? Are you getting regular exercise? Are you sleeping? And those things make a huge impact. So once I started integrating that into my care of patients, I got much better results. I was working initially for a big public hospital in New York City, and I discovered that people who have public insurance in New York City have access to a big network of public park and rec gymnasiums with pools, with workout rooms. They could actually, if they have public health insurance, they can go for free. And I started talking with my patients about, many of whom had been homeless, didn't have a lot of money, but they could go to the gym and work out, and they got fantastic results. When they took me up on those sorts of things, they got really great results, because you're absolutely right. It's a whole life. It's like a lifestyle issue. How are you living? How do you fill some of the needs that maybe drugs were filling with other things, other sources of pleasure, other sources of feeling good? So all of those things are correct. That said, there are always going to be, and I also mentioned treatment. There are really good treatments, and there are many people who do incredibly well and are able to get completely off of any non-medical substances. I wouldn't be in the field of addiction treatment if I hadn't seen so much success on that. So we absolutely need treatment, specific addiction treatment for people who have very advanced problems. But there will always be a subset of people who just don't do well with treatment. They just don't. They've tried, and I've talked to them, they've tried a whole lot of different kinds of treatment, and it's just not working out. They may not even, especially among young people, they may not be at a point in their lives where they really recognize the need for treatment. And what we want to do is keep them alive, because those people, given enough time, many of them do see the need for treatment with time. And so for keeping people alive, there is really good evidence from countries, from Canada, Switzerland, Australia. There are many different countries that have tried these approaches, Portugal, that have tried these approaches of medically supervised overdose prevention. And that's where they've been able to have really good success preventing overdose among people who just either aren't seeking treatment at the moment or haven't been doing well with treatment. So for that subset of people, the exercise, the good eating, the sleep, the treatment, those things they're not going to be the answer. I also think we need to invest in making sure people have access to fresh foods, get rid of food deserts, get people stable housing. Unstable housing and homelessness is very directly correlated with overdose risk and problem substance use. There are a lot of different things we need to address all at once in order to really make a dent in this problem. But we can't forget about the people who just can't stop using those drugs or won't in the moment. And I've seen also how people evolve over time. They often look very different given 10 years, 20 years, they're 5 years, they're at a different place in their life. And had they not been kept alive, they wouldn't have a chance, you know? So for those people, it's very strongly evidence-based. This idea of medically supervised overdose prevention, it's been shown to prevent an enormous number of overdoses. We are in the middle of a very big crisis in the country. You know, we've never had this level of overdose death. No country in the world has had the level of overdose deaths that we're now experiencing. So we're really in a crisis mode, and we need to use as many tools as we can to keep people alive. But I wouldn't neglect any of those pieces that you just laid out. They're all important.
Yeah, thank you for telling me. I think some stuff I think one of the things of maturing and learning about these complex issues is I may myself personally be against something, but at the end of the day, if there's evidence for it works, it's like I got to put my personal bias aside and understand this is better for the good of society, if that makes sense. And I'm glad I'm having this conversation with someone like you teaching me this, because even though I still like feel some stuff I just think shouldn't happen, if it works, hey, you know what I'm saying? If it works and it's helping people, I'll support it. I'm not going to put my ego into this and speak on like overstep on something I don't know. I'm glad that you laid that out, because I think that's really important for other people to hear who maybe feel similar to me at first.
Well, thank you for your open-mindedness. I have to say a lot of what I've learned about addiction is counterintuitive. You know, it's counterintuitive sometimes what's helpful, what's not helpful. I certainly myself have had these impulses that what we need to do is just get rid of the dealers, you know, let's just get rid of these dealers. And then it turns out it's so much more complicated than that. So
Yeah. When it comes to that, I know a lot of them now even invest more into drug testing than their own product, or at the same time, they don't do their own product. You see some drug dealers and they look like healthy guys. You wouldn't expect it. And they're generally very intelligent people, not kind of the stereotype you'd recommend or just you'd hear about. And, you know, it's just at the end of the day, I think when people forget is dealers are just businessmen. You know, yeah, they're just under the cover, so they're not, you can't really, when it comes to law, like put a grasp on people too, because people are getting smarter, especially with something like this. And it's another issue in itself. And I think I'm not pro drug dealer, but some of these people aren't bad people. They're just trying to make a living, and they might be good people, and maybe they get a bad batch. And I think when it comes to addiction too, I really agree with you when it comes to um the prohibition is bad, because what I've realized, it's not a black or white issue. It's very, very gray. It's like trying to solve a calculus equation. It's like, ooh, we got a lot of variables to consider.
that's so well put. So well put. And so there are two different kinds of drug policies out there. At least those of us in this world talk about supply side and demand side drug policy. So supply side is the interdiction, the crackdown on suppliers. And the demand side is let's get people to a place in their communities where they don't even look for the drug, you know. Let's make their lives better and provide other kinds of alternatives, including education about the risks of the drugs, so that they're not interested in buying them. And so that is where the payoff is. We have really robust data from different countries that land on different sides of that. And those countries that really focus on demand side, reducing the demand for the drug, have much better results in terms of numbers of people with problem drug use and overdose deaths and other kinds of harms from drug use. So it's really based on that I'm so committed to getting the message out that we need to focus on the demand. We haven't spent nearly as much money or time. Speaking of taxpayer dollars, I totally agree with you. We want to get good value out of our taxpayer dollars. And that's where we get the value. We've spent billions. We've spent billions of dollars on supply side law enforcement around illegal drugs. And the overdose death rate keeps going up. The addiction rate keeps going up. So we've been investing on the wrong side of the equation. If we invested in the demand side, we'd be getting fewer deaths. We'd be getting fewer people with addiction. So that's one of those counterintuitive things. But we have good evidence for that.
I think that's a good talking point. That I think another big talking point, just because, I'm a journalist, I've covered this opioid crisis, especially here in New York, where it's been a big prominent issue in recent years. Another big aspect of this that I think both of you kind of hinted at in your responses were the stigma surrounding opioid use, and those who either use it, those who know people who use it, etc. It's a huge issue. Another issue that comes with either preventing or stopping people from seeking treatment or wanting to get treatment. So when we are talking about treatment, we are talking about the stigma that comes to it. How does that affect one's, I guess, want to get treatment, and also kind of how we as a society are coming up with other ways of approaching what Dr. Hansen greatly put as the iron law of prohibition when it comes to this crisis that we're talking about.
I think, is it all right if I go first, Dr. Hansen? Because I think you could ask. So actually, I'm in a fraternity at Arizona State, and I think those are two indicative things of, I think you know where this is going to go. And I kind of quit a lot of the chaotic lifestyle to pursue my own health and happiness. And one of the I think when it comes to men and kind of the psychology, I almost when I really helped a lot of my friends overcome addiction and do better things with their life, it's almost well, and I think that I this kind of anecdotal, but with men, they kind of hate being pitied, oh no, don't do this, you're so bad, or this. And I just experienced my friend who I helped intervene, his girlfriend is you need to fix him, you need to do this, this, and this, and just kind of overblowing it and kind of overwhelming the situation. And this is from someone, his girlfriend did not do any drugs, and she's drugs are bad, drugs are the and she's a borderline alcoholic. You know what I'm saying? It was kind of counterintuitive. So one thing that really worked for me, and keep in mind, this is anecdotal, I'm kind of just speaking generally, is sitting him down as my friend. And if someone who has done these things with him, I'm hey buddy, I love you. You're so much more than this. You cannot allow yourself to be on this reckless downward spiral when you have so much more potential. And it seems like what really worked for me to help people change their lives in this aspect was kind of just being level to level with them. I think what realized dude, I've done this. I'm not here to put you down. I'm just here to know that your inherent self-worth and value is so much more than your dependence on this substance that is probably laced with said fentanyl, or I remember one time was even laced with a muscle relaxer. And I think that he's really changed. He really kind of got his life together. I know other people, it seems like the stigma of just saying drugs are bad, you're a bad person, people are going to push back against that. But if you have some experience, or you say it because you care and you kind of validate them and what they're doing, but kind of seek more, it seems like they're willing to be hey, you're right, I should be better. Because if we focus so much on the negative, they're just not going to want to change. But if you focus on, I think, people's potential to be better and do better, I think they're going to do a lot. They're going to be willing to try and slowly make the change to, like Dr. Hansen was saying, live a healthier lifestyle, because it's about the lifestyle. It's not necessarily about just that one particular thing. And that's where I think I'm kind of beating the bush, but I'll let Dr. Hansen speak and maybe add and educate me on what I was saying.
No, that was beautifully said. You're illustrating one of the really key components for pushing back against the stigma of addiction and drug use that often prevents people from getting good information and getting support when they have problems, which is, peer to peer. people who are able to educate others that are in their position, and when they've had struggles with drugs themselves, to disclose that. So it's kind of, we're in a society that has been on this just say no campaign for many decades. I don't know if you all have encountered a just say no kind of campaign in school, but that started in the 1980s with Nancy Reagan, who came up with that, the wife of President Ronald Reagan, who came up with the slogan, just say no. And it really took off like wildfire. And there were ads when I was younger on television that started off, Partnership for a Drug-Free America. It started off saying, this is your brain on drugs. And it showed these frying eggs in a pan. And so the idea was scare tactics. The idea was showing people how horrible addiction is in order to scare them off from trying drugs. And what that I think it was well-intentioned, but what that inadvertently did was it created this idea that addiction is so horrible, and the people who are engaged in addictive behaviors are so horrible that they are this other kind of person. Like they're such a terrible other kind of almost inhuman person that you don't want to have any interaction with them. And what that meant is for people struggling with drug use, they didn't want anyone to know, right? Because that was going to put them in this horrible other inhuman kind of category. And it put a lot of people, it isolated a lot of people to struggle with drug problems on their own and not be able to admit to that or talk with anyone or get good information or get good help. And so what we have to do is go in the other direction. Rather than putting up a lot of scary images and silencing people, we want to open the conversation. We want to give accurate information. We don't want to make drug use seem glorious and without risk by any means. But we also want people to have accurate, reliable information from people that they can trust. And that's often peers, like in college, that's often other students who can speak from experience, other students who've had struggles with drugs and figured out how to handle them and who've gotten really good information, because people trust people who are close to them for information. And when peer educators go out there, whether they're formally, designated peer educators or whether they're people who just care about their communities and their peers and want to get good information out there, and who, if they've had a struggle with substances themselves, are willing to go out on a limb and disclose that to other people in order to humanize the problem, in order to show people that a person who struggled with drugs can get themselves to a better place. Those people have an outsized impact. We as humans are geared to listen to the people who are closest to us, the people we can trust. And if we create an atmosphere where people can talk about their problems with drugs, they can be open about it and not fall into that category of this, evil, threatening other category of human or non-human. If we can create that kind of atmosphere, then we'll get much further, because people will have accurate information. They will have someone to go to if they're worried, if they're having problems, if they need help. People will not be isolated with their problems to suffer alone, which is often the case now. That's one of the real tragedies of the stigma surrounding addiction now. People who most need help are the least likely to get it, because they feel as though they can't tell anyone and there's no one they can go to for help. So everything that Ronan just said in spades, I think that is exactly the way forward.
I think another thing which is unfortunate too, when you mentioned education, is like trying to find information on Reddit and 4chan. It's like, oh, am I going to die tonight? Like, I'm going to be up transparent. I'm not going to get into detail. I like to go to festivals. I think everyone has experimented once or a few times in their life. And there have been a few times where I've had to do some very, very extensive research instead of just the DEA putting drugs are bad, instead of, okay, maybe if I do this, how could I do this safely? And if maybe I shouldn't do it at all. It's like the idea of that you can't tell people not to have sex, but if you educate them on how to do it safely, or just the bigger picture of social and scientific of what it does to you, I think people are more inclined to just kind of make the personal decision to choose what is best for them. In that instance would probably be not doing said horrible thing with drug, or doing it a lot less. and really kind of help contributing to the ending of overdose, because people are intelligent to know what the substance does, what it does to their body, how much is too much, and all kind of very important things to kind of wrestle with.
So well put. The one thing, speaking of festivals, I visited in Amsterdam, which, as you know, has a very different drug policy. I visited a drug checking department. They actually send people, government officials, to festivals to do free drug checking. So that's a whole other vision of the world, right? That's, they want to make sure that young people have good information about what they're getting. That's a very different approach. It's an example of harm reduction, the idea that what we want to do is keep people alive.
Absolutely. And to kind of, I guess, just like wrap up our conversation here, are there any other points that either you feel are also important to include in this conversation, even with regards to maybe other forms of treatment, such as, methadone clinics, drug centers, whether that's outpatient or inpatient treatment centers, anything else that you both feel is important to include?
This is going to be quick and a little controversial, but I think one thing that kind of can maybe help people stop drugs is never to feel like they're a victim to drugs, that they're always so much more. Whether it's fitness, poetry, something that helps challenges your mind, your brain, and your body to do something great, pursue it. If someone is judging you because it is good for your health, and is in a stigma that normalizes, even though this is opiates, I'd even say drinking so much, and it's pretty bad for you as well. And I'm not saying don't drink or do anything, but in a society that has normalized drugs when it comes to art, media, and so many things, if one is struggling with this and they want to take the measure to better themselves and people just don't think they're cool, I say don't listen to them. Put yourself first, put your being first. Who cares what these negative people think? And you're never a victim to these drugs if you're struggling, and your inherent self-worth is always so much more than substance abuse. And I say, press on.
I don't know if I can add to that. That's beautifully said.
Well, perfect. I think that is the perfect quote to end on here. So thank you both again for taking part in this podcast. I think a lot of people have definitely learned a lot from this experience. And I have, and Ronan has already said he has as well. So no, thank you both. I think there's definitely a very enlightening conversation when it comes to a very prevalent issue in society right now. So thank you for listening, and thank you to those at home as well for listening. Next week, we'll be back with book bans in the country. So stay tuned for that. Until then, have a good one.
You too. Thank you.
This podcast was brought to you by Our National Conversation, a place where students generate policy solutions to the biggest problems facing America. Join us in freeing political dialogue from hyperpartisanship. To learn more about what you heard today, check us out at ournationalconversation.org. You can also follow us on social media at Our National Conversation to show your support and keep up with our latest efforts.